Hi guys. Hello beautiful people. This is Dr. T, and yeah, welcome to Clinical Medicine with Dr. T. So guys, I haven't done a video on a patient that I saw for a long time. A patient that I saw. I haven't done this kind of videos for a very long time. Okay, so before I start, so guys, I don't have a lot of subscribers at the moment, so when you guys drop me a comment, I reply to all the comments that I get. So I think this is a perfect opportunity for you guys to ask me questions, or to if maybe there's a topic that you want me to cover that I haven't covered. Maybe you've been anxiously waiting for me to cover it, but I just have not. So you feel free to comment and just ask me to cover that topic that you want. I think since we are a small community at this point, it will be easier because I respond to all comments and queries. There are people that I meet on the streets, in the hospital, in spa, students. Then they'll be like, "Can you do a topic? Can you do this topic for us?" And then I do that. So yeah. And if you guys, if you don't really have a comment, or you can just comment and say, "I have subscribed," then that will be sufficient. That will be enough. So keep liking, keep sharing, and all of that. So guys, the reason why I haven't been doing a patient that I saw videos is because I'm in psych. This is my last month in psych, and maybe I'll have to do one or two before I leave. But the cases that we see here, unfortunately, it's substances. You know, there isn't anything interesting about substances. I mean, if we have someone who's got psychotic features, but they are not on any substances, you hardly get that. I think those are much more interesting patients. So about, I think 98% of the patients that we see in psychiatry, they've got they are using substances, their own substances. Yeah, so but I'll try to do one or two, but I'm not really encouraged to do it anyway. So I saw a patient on Saturday. It's actually someone that I know. So because they know that I work in the hospital, so they're like, "Can you see us when we get there?" So I was like, "Okay." So I went to see them on Saturday. I was not working, but I went to see them. If you are working in the community where you are raised, where you grew up, you are gonna have people say to you, "I've got so and so in the hospital. Can you please just have an eye on them?" Not necessarily that you're gonna go out of your way to go and see them, but if you can, you can. And also just to see them, to be there, even if you are not the treating doctor, the fact that you'll just be there for them and just show them where things are, that usually is enough. But this one, so they called me before they came that they're coming to the hospital and they would like me to see them. So I was like, "Okay, sure." So it's an old man, 70-year-old. Obviously, because of ethical reasons, I will not divulge a lot of their private information. So this is purely to educate. This is purely to make us to understand, or to make us to treat these patients when we see them again better, because you are gonna keep seeing a patient who's got these signs and symptoms, and for us is to know what do we do so we can always improve. So if I tell you what I did with this patient, you can also decide, okay, next time I see a patient presenting like that, I'll remember what we discussed. I will do the same thing, or I will do more than maybe what I did. So the main thing is to educate each other, to share information. This is clinical medicine. This is clinical medicine. This is what I'm gonna be telling you now. Is it's things that I did with the patient, the practical things that I did with the patient. And this is not actually about the patient. It's about the condition. It's not about the patient that I saw on Saturday. It's not about him, but it's about the condition. When you see a patient like this in the future, what will you do? What will you think? What is it that you don't want to miss? And things like that. So this patient is 70 years old. It's a male. So the history is that he has been getting abdominal distension for the past 3 weeks, and that has got poor appetite, and that he's having body pains for 3 weeks as well, and he's just always feeling unwell. So this is the history. So when I was looking at him, asking him all this, I saw already that he's got yellow eyes, he's got jaundice. So as I was taking the history, I already know that I'm dealing with someone who's got abdominal distension and has got jaundice. So I continued taking my history as usual, and then at the end, already as I was taking the history, I already had an idea of what might be wrong with him, because of that. So so this is what he presented with, and that he was losing weight as well. So his past medical history is hypertensive. They didn't have a card for me to see what drugs are they taking, and they also didn't know what drugs he was taking, because he was brought in by sister-in-law. So RVD unknown. And then he had no surgical history, and then because of that yellow eyes, I had to go to substance use already. They admitted that he used to be a heavy alcohol drinker. He only stopped about a month ago. Like, he was using alcohol excessively for years. He said over 20 years. I believe it's more than 30 even, because he's 70. Most of the people here by 40 they're already drinking. You hardly get someone who starts drinking after 40 years. I mean at 50, 60. Unless they've got serious psychological problems or social problems. But most of our people here, by 40 they're already drinking. So for him to be 70, it means at 50 he was already drinking, at 60 he was already drinking, at 70 he was already drinking heavily. So we can think here about plus minus 30 years this guy has been drinking. Okay. There wasn't so I didn't even bother about family history at this point. Yeah. So from there I went to the examination. The thing is, the way I'm writing now, my notes are scanty, but they've got enough information, right, to make a diagnosis. And that's what clinical medicine is about. Clinical medicine is not about taking a deep detailed history and find out 60% of that history, you don't really need to move forward. You don't really need that 60% information to make a diagnosis. So that's what clinical medicine is about. It's about getting what's gonna work for you, what you need to move forward, getting that crucial information. So fine. So he looked. He had. Okay. So he had jaundice. He had. He looked. The abdominal distension was just obvious, guys. Ne? As if he was kind of pregnant. It was just obvious, and he also had clubbing. So it turned out. I forgot. Yeah. Sorry. So it turned out that he stopped smoking when he was in his 30s. There wasn't a specific reason. Sorry, there wasn't a specific reason why he stopped. He just stopped. So he had clapping, and so he had clubbing. He also had so his BP was 122/71 with a pulse of 85, and his sets were 89. No, they were 85. No, they were 95. His sets were 95 on room A. His temperature was 37.1. So guys, if you this is the second time we are covering a patient who's got obstructive jaundice, right? So please watch the other patient that I posted, I think about 2 months ago. Just look that, because there I did speak more about the history and all of that. Here, what I'm trying to rush to is the blood results and also the ultrasound investigations. That's something I want to show you there. So he had this. So when you look at his abdomen, his abdomen was distended, ne? He had engorged umbilicus. He had no scars. He had no spider nevi. He had the abdomen was soft, right? And it was non-tender. He had a massive hepatomegaly. His hepatomegaly, I didn't do a liver span, but it was about 4 centimeters below the costal margin, and regardless of whether he was inspirating or expirating, so about 4 centimeters, and it was crossing the midline. So it was crossing the midline. It was non-tender. It was smooth. This hepatomegaly was non-tender, and it was smooth. He had no splenomegaly. Yeah. So that's his abdominal examination. So after that, I did a PR. He had pale stools, and he had a bulky, smooth prostate, right? The reason why I did a PR, I wanted to see if he had a pale stools. It wasn't because I was looking for a prostate, but because I was already there. So I just had to complete my PR examination by doing the prostate as well. So, yeah, so he had no hemorrhoids. And then when you look at his The respiratory was fine. The CVS was fine. The legs were not swollen. Yeah. So I realized that as he was lying flat, when I was examining him, when he was in a supine position. Oh, sorry. The other things that were in the abdominal examination, he had a positive fluid trail. And I called the students to see this. Positive fluid trail plus shifting dullness. The students that are watching me now, they will know about these patients, those that were with me, because I did call them when I was seeing this patient. So already I knew that he had ascites. So as he was lying on a supine position, I realized that he was also getting a bit uncomfortable, like he's struggling to breathe as well. So what I did is I did acetic tape and I drained about 700 mils of acetic fluid. And then I asked him to go and pee, and then his urine was coke colored. His urine was coke colored. There's a urine that is on the channel that I posted on Saturday. That's his urine. So his urine was coke colored. So right now, at this point, I knew what I was dealing with. So I was dealing with a 70-year-old who had jaundice, who had a pale stools, coke-colored urine, as we all know, these features are pointing us to obstructive jaundice. But we need to understand what is the cause of the obstructive jaundice. And there were so many things that were in this patient that trying to pinpoint his diagnosis was going to be difficult. He had ascites. Ascites is not always there in obstructive jaundice. It's not always there. Something else is causing it. We need to find the reason why he's having ascites. And he had a massive hepatomegaly. Hepatomegaly. So we need to think about what is happening here. The fact that there was hepatomegaly, I knew that there's something happening with the liver. And the liver, it was not enlarged because he had portal hypertension. Because this patient didn't have features of portal hypertension. He didn't have hemorrhoids to start with. Remember, with portal hypertension, you get hemorrhoids. He didn't have swelling of the legs. Because when you have portal hypertension, it means the blood in the legs is not able to pass through the liver and get to the thorax. So he didn't have swelling of the legs. He also didn't have spider nevi. He didn't have no history of varices as well. So I didn't think that this patient had portal hypertension because of those reasons. In any case, my assessment was obstructive jaundice, query hepatocellular carcinoma, and also query pancreatic carcinoma. Those were my differentials. So what I did is, this was Saturday, right? So what I needed to do now was I was happy that he had normal vital signs, because remember, when you've got obstructive jaundice, one of the things that will kill a patient instantly, as I've always said, it's acute cholangitis. So you cannot have a patient who has, it was very crucial for me to get to a point where I say this is obstructive jaundice. And number two, if this is obstructive jaundice, do we have cholangitis? So because of the normal vitals, the temperature was normal, the BP was normal, the pulse was normal, temperature was normal, BP normal, pulse normal, and he was afebrile, even clinically. So I didn't think that we might be having acute cholangitis. So I was happy to discharge this patient home. And after I did that aesthetic tap and drained about 700 mils of fluid, and his the fluid that I got there, it looked just like his urine. It was also coke-colored as well. It wasn't straw, or it didn't have blood. It wasn't a clear fluid or a straw-colored fluid. So it was dark, as such that that aesthetic fluid was so dark. It was just like, it looked like it was also coke-colored, such that if you put the two of them, the fluid and the urine, you wouldn't differentiate which one was which. Okay, so, and also, as we have said, that one of the things that will kill a patient who's got this is patient who's got hepatic failure. My patient was very stable in terms of all cases. So the plan now was first to confirm the obstruction. So that day I took bloods. The bloods that I took LFTs, the so-called LFTs. I took albumin. I took PSA, alpha fetal protein. I took FVC. I took I did ion studies. I did so I took that fluid, acetic fluid, for tests as well. White cell count, protein. Oh, I also did a hep screen here. Hep screen. Hepatitis screen. And what else did I take? Oh, gene expect. I too, and also white cell count. What else did I take? I can't remember the other things I took. I took there on the phone. Okay, so I've got the blood results with me here.